President. Very good morning to all the viewers here. And I'm Dr. Kalaivani from the Department of Surgery. This is a very exclusive program for women, Women's Health Awareness Program 2022. We have experienced speakers over here who will listen to your queries and who are ready to answer your queries. I first request Dr. Shalini Nui, who's our Vice Principal, to give the welcome speech. So before starting that, I request all the women over here to first break the bias. The theme of Women's Day, International Women's Day this year is break the bias. So let us break the bias first. Let us take care of the health. So I request Dr. Shalini to please give the welcome address.
Wishing you all a very pleasant morning. For those of you who are in India, if there are anyone who has joined from outside or from other time zones, wishing you all a very pleasant day. Greetings from Ramaya Medical College, Bangalore. Many of my colleagues and my friends here, they felt that as health professionals, it is our responsibility to bring to all women awareness about health programs and health issues that are commonly affecting them. And therefore, this Women's Health Awareness Program was begun in the year 2014 as an endeavor from the women faculty of Ramaya Medical College. So, with this, I would just like to tell you, this was begun by our Principal and Dean, Dr. Medha Vai Rao. She has sent her best wishes for the program because unfortunately she's not able to be here this morning. She's busy in the hospital and therefore we'll be continuing with the program with our esteemed lady colleagues. I just want to give you briefly some inputs about women in general in India. We are still, as this year's theme says, we are still biased unfavorably. We still have a huge maternal mortality rate. We still are less empowered than men. Although the World Economic Forum says that the more number of women that are employed in the workforce, the more it contributes to the gross development GDP. And therefore, in the words of Indra Nui, who was the former PepsiCo CEO, she says the career clock and the biological clock are in complete conflict with each other. So therefore, it is our endeavor to see, and we hope that you also join us in seeing that women are empowered, women's health issues are addressed early so that we can contribute equally to the environment, to the community, to the society, and to the country in general. We hope you find the talks by our faculty very useful, and we hope you take it forward and spread the word with your friends and relatives. I think information or introduction of each faculty will be given by Dr. Navya as we go along. Okay? Thank you very much. Have a good day.
Thank you, ma'am. Dr. Navya, to please take over.
Thank you, ma'am. Good morning, everyone. Women's Health Awareness Program has a mission to inform and empower women to take responsibility for their own health, understand their health options, and identify services, thereby increasing equal access to services, resources, products, and to get the best help, that is to prevent and reduce poor health. So Women's Health Awareness Program is actually a multidisciplinary approach which is centered around the goals of the disease prevention, control, and management. So MS Ramaya Medical College is proud to present Women's Health Awareness Program yet again this year with an apt theme, Gender Equality Today for a Sustainable Tomorrow. So getting down to the brass tacks, providing a head start to the event will be by Dr. Sumati, Professor at HOD Department of Dermatology. She will be talking about women and hair loss, all you wanted to know.
Please raise your hands for questions.
Kindly raise your hands for questions.
Dr. Sumati.
Hello, good morning to all of you today. I am Dr. Sumati and I am a dermatologist and I will be speaking to you today about hair loss, all that you wanted to know. At the very outset, I would like to thank Dean Madam, Dr. Medha Rao, as well as her team of senior administrators for giving me this opportunity to address all of you on important aspects of dermatology for a general health awareness. So the topic for today is hair loss in women through their lifetime. Now, I try to put together pictures of a young woman as well as an older woman. And whereas it was very, very easy to find young women with such beautiful hair, it was quite difficult for me to find an older woman. And I thought a celebrity, and the search took me finally to Neena Gupta, who got reasonably good hair at her age. Now, the discussion of hair loss in women through their lifetime, that being the heading, I have decided to, because women have different reasons for hair loss through their lifetime. So I have categorized into three parts. The first part will be 10 years of age to 30 years, 30 years to 50 years, and 50 years and beyond. Let's come to the ages of 10 years to 30 years. The most common cause of hair loss that we see in this particular age group, this particular duration of 20 years, is polycystic ovarian syndrome. This affects 6 to 20% of young women, and many of these women also have hirsutism and acne. Hirsutism means that they have nail-like hair, that is thick, dark hair occurring in parts of the body where they would not like them to be, places like the face, the neck, the chest, and such areas. And conversely, they have less hair on the scalp. And the type of hair loss seen there is usually of the male pattern. So we can very well imagine the anguish that these young girls go through. And they also have acne, which are not very conducive to treatment. Now, the other issues these women have are weight gain, menstrual irregularities, acanthosis nigricans, which is actually a velvety kind of hyperpigmented skin, which is seen on all the folds of the body, more so on the neck, as well as the axillae. They also have insulin resistance. The gynecologist will be discussing this in greater detail later. So the type of hair loss seen is of the androgenetic alopecia type, which is also called as female androgenetic alopecia. Now this is the kind of hirsutism that these young girls present with. You can see the mustache hair, the beard hair, as well as the acne on the right side. So, and you can see the scars on the face indicating acne of long duration. The clinical appearance of hair loss is usually seen on the sides and the vertex of the hair, that is the top of the head. And many of them have a receding hairline like this. They have of course, in a very early stage. So sometime later, this young girl can develop a receding hairline. Now you can see the hair loss affecting the frontal area of the scalp. The management of PCOS-induced hair loss is, as PCOS is a complex disorder, usually managed by endocrinologist and the gynecologist. So the hair loss may show improvement after several months of therapy by the endocrinologist and gynecologist. So dermatologists do an important role to play. The improvement is likely to be good for these patients, provided they have a good compliance with the treatment. Now, coming to hair loss between 30 and 50 years of life. This, as we all know, is the most active period in a woman's life. Unfortunately, the maximum cases of hair loss are seen in this age group. There are majorly two types of hair loss. The first one is telogen effluvium. This could be either acute or chronic. I'll be detailing this in the next few slides. And the second type is what is called as the female androgenetic alopecia, which you have already just now heard from me. Now, coming to telogen effluvium, this is a generalized hair loss that is seen and is by far the most common kind of hair loss the patients come to us with. And if it is lasting less than 6 months, it's called as acute. If it is lasting more than 6 months, it is called chronic in an arbitrary manner, clinical manner. Now, acute telogen effluvium, this usually follows fevers. Most patients know that typhoid can cause hair loss of this manner, but many of the patients do not know that dengue, chikungunya, and even COVID-19. In fact, most cases of acute telogen effluvium at present in our OPD is following COVID-19. They can also follow vaccinations, and notably COVID-19 again. Severe trauma, major surgery, following childbirth, which is again a very, very common cause of telogen effluvium. Acute blood loss of any cause, and the hypothyroid state, I can add here hyperthyroid state also. So how does the scalp look? What do we see? Overall, they have a normal look, but patients always complain bunches of hair come off daily, and they bring the bunches of hair to the OPD to us. I'll just show you the picture. Now, if you look at this picture, you can see an almost normal looking scalp. You would say quite good hair. But if you look at the trichoscope picture on the right side, that is an instrument where we can magnify the scalp as well as we can magnify the type of the look of the hair. You can see that good number of hair are there. However, there are a lot of small gaps in between the hair shafts, hair roots. And you can observe there are two to three hair coming out of a single opening, which means they are normal hair. This is a cardinal feature of telogen effluvium. Hair pull test is positive. Hair pull test is a slightly a crude test, but it can easily give us an idea of telogen effluvium, where in a coordinated manner, we pull out some hair, around 60 hair from the scalp. And if we find more than 4 hair landing into our hand fingers, we say that the hair pull test is positive. That indicates acute telogen effluvium. How do we manage acute telogen effluvium? We take a very careful history, a lot of time has to be spent. Remember, the patients are all quite anguished ones. So spend time with the patient and we test for acute iron deficiency by doing a serum iron, iron saturation, and serum ferritin. Serum ferritin is not what shall we say, complete indicator of iron deficiency, but it's very useful to do that in practice. And of course, the thyroid profile. Now, what happens to telogen effluvium? Almost always self-limited. Reassurance is the single most important step. It depends upon the camaraderie you have with your patient and how you're able to handhold the patient. And minoxidil 5% solution can be used for short periods for anxious patients with good results. Now, the other type of hair loss in 30 to 50 years age group is the female androgenetic alopecia, a more difficult one. It usually starts in early 30s. Inheritance is seen in many patients just as in the males, but only thing is not as clear an inheritance as in males. There are at least 3 stages seen. Let's go to these stages. This is the first stage where you can make out that the parting line has widened a bit. Here and there you can see hair loss. The second stage where a more diffuse increase in the width of the parting, and it is obvious here that a lot of hair has been lost on the sides too. And the trichoscope, you can see this hair and compare it with the hair that you saw in the previous picture, where you can see very thin looking hair and hardly one hair from the opening of each ostium. And the hair is thin and small. This is typical of androgenetic alopecia. Now this is the last stage or the third stage, where practically the entire vertex shows bald from the side view. But what you have to note is that in most cases, the front hairline is always maintained. What are the investigations we do? We can do a trichogram where the pulled hair, programmed pulled hair 2 to 5% gives good results, but over prolonged period of time, it takes minimum 6 months for improvement to be seen. If the hormone profile is normal, then topical minoxidil alone for long periods. However, in recent days, we have added new methods to improve our results. We use PRP, what is called as platelet-rich plasma. We do microneedling, where small injuries, programmed injuries are produced on the scalp, and the PRP can be injected into those gaps. We can also inject minoxidil into after microneedling so that there is good penetration. Then lower level light therapy, LLLT, is a very promising field, and this is where we use what is called as a laser cube to increase the blood supply of the scalp. And in those who are not responding, we can do hair transplantation. Hair transplantation is a complex method in women and is beyond the scope of this talk. So we'll go, now this is a picture of a young lady with androgenetic alopecia who has done quite well with minoxidil. It's taken about a year for her to have this much of improvement using minoxidil therapy alone. Now coming to hair loss 50 years and beyond. So these are postmenopausal women most times, and the androgenetic pattern is the most common. There's a diffuse thinning in the scalp of these women. If they have comorbidities such as hypertension, diabetes, metabolic syndrome, and thyroid excess or less, then diffuse thinning is likely to increase further. Management is by using minoxidil solution, probably lifelong, 2 to 5%. And finasteride tablet, this is a medicine which cannot be given for women in reproductive age group, but in postmenopausal, they can be safely given. 1 milligram per day, or dutasteride, 0.25 to 0.5 milligram per day, have given good results in evidence-based medicine studies. Now to summarize, while men either go bald or they do not, women may have hair loss due to different causes across their lifetime. Early treatment can reverse hair fall in many cases. Treatment strategies have improved tremendously in recent years. Thank you very much for your time.
Now we are talking.
Thank you, Dr. Sumati. That was really enlightening. The session is now open for the audience to ask their questions. Dr. Sumati will be answering them.
Put in chat box.
Are there questions in the chat box? No questions? You may please put in your questions in the chat box, or you may raise your hands to ask questions.
Chat box.
I have a question for you. Kindly put up your questions in the chat box.
Questions, what are the next?
So if the audience has any other questions, kindly type them in the chat box. Yes, does washing your hair every day increase the risk of hair loss?
Sumati ma'am?
Madam will be answering these questions in the chat box itself. Moving on to the next. Next up, Dr. Pragati will be giving us a talk, Professor of Respiratory Medicine, about cough and breathlessness. Know the facts.
Kindly start putting on your questions onto the chat box. We will either answer the questions immediately or we will reply to you in the chat box itself. Please feel free to ask questions.
Good morning, everyone. Hope we all find you in good health. These sessions will be little more enlightening. This is a very important topic because it is very frustrating to have cough and breathlessness and not getting treated. So I'll be touching next 8 minutes upon the main common causes of cough and breathlessness. As you know, most common in Bangalore is asthma, where the allergens are more during the winter seasons. And second most would be GERD, gastroesophageal reflux disease. Third most being sleep apnea, then vocal cord dysfunction. Now, after 3 waves of COVID-19 is one big culprit for dry cough. We have been treating these cases last 1.5 years. Then coming to wet cough, it is mostly post-viral. Then lung infections, that is the bacterial lung infections. Third most would be COPD, where it is more, as we have heard it, as more in smokers, but we are, as women, we are passive smokers as well as we have exposure to biomass. So again, wet cough is common in females. Then acute bronchitis and bronchiectasis. Bronchiectasis, generally any lung condition which is prolonged like tuberculosis or any long pneumonias or recurrent infection in childhood leads to bronchiectasis. So this is again one important cause of wet cough. So since I'll be touching upon asthma, just in a brief, it's a lung disorder in which inflammation causes bronchi to swell. It narrows the airways and there is difficulty in breathing. So common symptoms will be shortness of breath, cough, which is mainly dry cough. Later on, it converts to productive. Wheezing and chest tightness. Chest tightness, they will be telling there is not enough of breath I can take and I do my daily activities, I feel breathless. So these are the common complaints. This is how an airway looks like. This is the normal one, where the lumen is totally normal. The next pic shows that this is the asthmatic airway. The yellow part is the mucus, which is present inside the airways, and the redness is the mucosal edema. So these are the pathological findings which is present in an asthmatic. So we should be knowing what are the triggers. As I told in Bangalore, pollen is very common. Then dust at home when somebody is cleaning the ceilings and all, and then the exposure causes asthma. Furry pets, the danders of the pets, that is again one common factor. Change of weather from summer to winter, rainy season, from rainy to winter, these are again triggering factors. Cold, food allergies. I would like to mention these food coloring agents where there is monosodium glutamate. These are again common culprits. Then cold weather, I have already mentioned. Perfumes, yes, women like perfumes. So some perfumes, it doesn't suit everyone. So we should be very careful. Cockroaches and exercise. This is another another important entity, exercise-induced asthma. So we prescribe inhalers. I'll be just briefing you on. So most, apart from knowing the triggers, we should be knowing what are the severe symptoms where you should be coming to the hospital. One would be rapid breathing, shortness of breath, chest tightness, unable to breathe, the want of hunger for breath, then wheezing, that is that sound, cooing, cooing sound that comes from the throat itself. Then nighttime awakening, dry cough, and cough which is persistent. For women, persistent cough is very irritating because it causes urination, and that is very typical complaint women have when they come to OPDs, and increase in the heart rate. So how do we go about it? We have to prevent, we have to have a good relationship between the patient and the doctor. We have to reduce the exposure of the risk. Assessment at home. We have to have one small peak flow meter, the small instruments, which has to be used for regular monitoring at home. Then the questions we should be asking to ourselves if we are an asthmatic, that is it daytime, are the symptoms more in the daytime, is it in the nighttime, do I awake, do I get, I wake up because of the cough, do I have breathlessness while doing exercise? Then the most important features will be severe shortness of breath when I'm not able to speak a short sentence. So these are the symptoms where you have to have a medical help.
photos.
Now, how do we prevent it? So, dust mites, we have to remove carpets and upholstery, use cotton bed sheets instead of the woolen ones. Always sunlight should be there inside the room. Keep away soft toys, they are one culprit while in the sleeping area. Smoke, it should be a cigarette smoke-free area. Animals have to be removed from the house. Sorry to say, those who have pets, it has to be a difficult decision. Then coming to pollen, avoid flowering plants indoors and stay indoors during harvesting time because there's pollen everywhere in the atmosphere. Then other triggers, cockroach allergens, we have to spray insecticides, but then the patient should not be around. Indoor molds and spores attend to damp walls. Every time walls should be dry, there should be no leakages. Coming to drugs, painkillers have to be avoided. Paracetamol is the safest of all. Then physical activity, yes, you have to take inhalers before doing exercise. Then, as I had suggested, monosodium glutamate is one of the culprit in the food coloring agents. So, what should be our aim in the treatment? We should have a good sleep. There should be no exercise limitation. Lung function should be normal. Exacerbation should be less. And there should be we should avoid medication side effects. Steroids rampantly being used, oral ones. So, we have to avoid that oral steroids also. So, I'll be just telling that there are, in the treatment aspect, there are relievers and preventers. The relievers, they just open the airways. These are the drugs I meant. And the inflammation is also relieved by preventers. So these are the two main drugs which we have in our treatment, oral, inhaled and parenteral. Which one do you prefer will be the big question because everybody likes oral tablets, nobody wants inhalers. Inhalers, once we start, they say, everybody keeps asking, do I get used to that? Should I take every year? Why should I take inhalers? All that. So there is one slide to answer your questions. Oral, it has a slow onset of action and large doses are required and greater side effects and not useful in acute symptoms. Inhale, these are faster action, small amount is required and lesser side effects because it's less than 1% absorption systemically. So, and it is very, very useful in acute symptoms. So that is why we prefer inhalers and we orient everyone to use inhalers more than oral medication. Now coming to an important cause of breathlessness, this is sleep-related breathlessness. I want to mention this because yesterday was World Sleep Day and little bit awareness was required, I thought. So obstructive sleep apnea, it's complete or partial obstruction of the airways. And during sleep, it causes loud snoring, oxygen falls, and there is frequent arousals. These are the statistics, 2 to 6% in men, 1 to 2 in women. Now, if you are able to see this picture clearly, normally the sleep muscle tone decreases in a normal person, but if it is more than the required, then there is the airways decrease in the size, there is airflow limitation, and that causes snoring. So what would be the symptoms? The patient says daytime sleepiness is more, unrefreshing sleep is there, poor concentration, difficulty in driving when they are driving for a long distance, morning lethargy, nocturia, then decreased sex drive, headache, and GERD. This is a reflux. And what will the patient complain? He or she will say snoring is more, and suddenly the patient wakes up and they feel breathless, irritability is there. So some factors which are modifiable, some factors which are not modifiable. Non-modifiable, we'll just keep it aside. The modifiable ones are the obesity. So weight reduction would be an important uh, aspect which we would stress on. Cessation of smoking, alcohol use has to be decreased. Upper airway collapsibility, that can be prevented by oral devices. When we do the testing, if it is a very low index, we advise for the devices. Then genetic factor, we cannot do much about it, older age and male sex. So what does all this lead to? The consequences are very bad. It causes road traffic accidents, hypertension, cardiovascular risk is high, then cerebrovascular accidents are common. And it leads to right heart failure, causing peripheral edema, hypertension, and CO2 retention. what do we do about it? How do we diagnose? So you can see so many wires, but each wire is important for us. And this is a one-night study. It is called level 1 study, and it is done in a hospital. And after doing this study, we get some numbers. But one more thing I would like to mention, sometimes people, many people say, I have not a refreshing day, the day is not refreshing. So, but when we do these studies, they are normal. So we explain sleep hygiene for that particular phenotype. We tell them you don't take long afternoon naps. It should not be above 45 minutes, and then avoid alcohol. No caffeine before 6 hours. No heavy spices. Light snacks should be taken, and then there should be no distraction while sleeping, the noise wise. So the polysomnography, the wires which I showed, those are that test particularly gives us a apnea hypopnea index. So when it is low, we say oral appliance, weight loss, and CPAP. And if it is on the higher side, we have to give the machines. But getting used to machine takes time. We tune them, we educate them, and then we have a very regular follow-ups with the patients who are using this PAP therapy. PAP means positive airway pressure therapy, and various machines are there, various companies are there, so we make it as comfortable as possible to the patients. So, questions from the audience?
Please put your questions in the chat box.
Thank you.
First, you have to introduce. Thank you. Then
Thank you, ma'am. I now request Dr. Bharati Hirimat, Professor of Surgery, to give her talk. I have a breast lump. What to do now?
Very good afternoon, very good morning, rather, to all of you. Still time for afternoon. And to all the beautiful women who are logged into our program today. And maybe, I'm not sure, to the men who may be logged into this program also. So I'm Dr. Bharti. I'm from the Department of General Surgery. And I also run a breast clinic. And breast diseases, breast cancer are something very close, and cancer awareness are very close to my heart. So the topic I did put in the brochure as I have a breast lump, and what do I do now to draw your attention. But the whole thing amounts to breast. What I would like to bring about to everybody's notice today is what is breast awareness. Okay. So whatever the size and shape of your breast from outside, just a small understanding of the breast structure. Unfortunately, I do not have a pointer here. Navya, can you show the pointer to whatever I'm talking? So you can, okay. So one of you can see this. This is a cross section of the breast. Okay. These are your ribs. And on top of the ribs is your muscle. And this whole breast mound is placed over your muscle. Okay. Now the breast consists of skin with a lot of loose areola and connecting tissue and fat. And this is the main breast tissue, which you can see these grape-like structures are the breast lobules, and these are the ones which produce the milk. And these are the breast ducts which bring the milk from these lobules to the nipple. Now, this is the main area of all the breast problems that occur. You can get infections here, but the breast tissue, this is the breast tissue, and all your problems occur here. The commonest site for cancer is these ducts, second by this lobules, all the benign, non-cancerous conditions also occur here. Now, in a younger woman, this pink area would be larger and consists of more breast tissue and very little connective tissue. As we grow older, this breast tissue regresses in size and is replaced by more of this yellow tissue, that is a connective tissue and fat. Okay, so this is just a small understanding for us what's happening within the breast and what is the structure. So when we say, you may hear like nomenclatures like ductal carcinoma, if somebody of your friend or somebody unfortunately you know has had. So this is the understanding, small understanding of the structure. So what are the symptoms that should alert you and which should make you go to your doctor? One is a lump in the breast. So the commonest way a lump is noticed by self-examination, I'll be talking to you about that, accidentally, and the commonest time when it is noticed is during bath with a soapy hand when it goes over the breast. That's the best way, that's the easiest way, and that's the commonest accidental way that a lump is felt by a woman. Sometimes the partner may tell you, sometimes your examination, which is you have gone to a doctor, may pick up this lump. Occasionally, there may be nothing in your breast and there may be just a lump in your armpit. The next symptom that is very common and with which patients come to us is pain. Now, one type of pain that the patient may have is she notices pain. It is same next day or increased next day, it is remaining same, not going away, third day, fourth day, fifth day. It just doesn't go away. She is waiting, wishing it to go away. It doesn't go away. And she takes some painkillers, it still persists. Now, this is a very important kind of pain and not to be neglected. The next kind is she notices some pain and heaviness. It's mainly a heaviness and discomfort in the breast. And here it will be in both the breasts. It will not be in a single breast. And this will go on increasing, and during her menstruation it is maximum. And a week later, she will suddenly realize that it's no more and feel very happy. Only for this whole thing to repeat the next cycle. So this is called cyclical mastalgia. Mastalgia is pain in the breast. So this is usually due to hormonal changes. The third symptom, common symptom that a woman may notice is nipple discharge. The commonest is watery, sometimes a thick discharge. Occasionally it may be milky in a non-lactating woman. And the most ominous of all is if this nipple discharge is blood stained. Then the other thing to look out for is a nipple retraction. So some women may have this nipple retraction since birth. But if you have noticed a recent retraction in one of your nipples, and you are not looking at your nipples every day. So there is a way to examine and be aware and detect it at earliest. We'll have a look at it a little later. It's not one of the earliest things that a woman will pick up. You may notice redness and swelling. Now this redness and swelling most of the times indicate some kind of infection, but also it rarely may indicate cancer. Unequal size. In many women, there may be a 10% difference in the size of the breast. However, if you notice that recently one breast is looking a little larger and you feel some heaviness on that side, and you try to feel but you're not feeling any lump, but it is looking larger to you. So this definitely calls for a visit to your doctor. And if you do notice skin changes, these are the most easily visible. If there's a puckering of the skin over your breast, if there's an orange peel appearance, I mean, this is a very delayed thing to appear in cancer, but it is one of the things. If you notice that suddenly one breast showing more dilated veins, or if you see some nodules over your skin, these definitely indicate or necessitate a visit to your doctor. Now, stop moving, it's like, yes, sir. Yes, sir. Yeah. So you may notice this blood-like discharge is very small, but if it is blood yes, you need to see your doctor immediately. If it is watery, you can wait a while. Here you can see a slightly water peel appearance. You can see that there is some nipple excoriation. This is the lump that you may see. Again, this is a very large lump. You shouldn't wait till something like this happens. You can see the nipple retraction. And these two pictures, I wouldn't like to show you. They're very gory and scary for the non-medicals, I think. So what do these various symptoms mean? They can just mean a variation in the physiological change, along with changes occurring with the physiology of your hormonal changes. It may mean that they're just benign, that is, non-cancerous breast diseases occurring. The one which I showed you in that pink area with grape-like structures. It may mean that you have some sort of infection, especially the redness, and if there is pain, or it may mean cancer. Now here lies the problem, because the symptoms for cancer and non-cancerous conditions are similar, and you have no way on your own to say yes. You can just wish that this may not be cancer, but there is no way you can tell, and no way I can tell unless further tests are done. So what should I do now? First thing, do not panic. We have seen patients who notice a lump or some discharge. They panic. They may not panic outwardly, but they panic and they are very worried, scared, go into depression. And then some family members are noticing, why is she so quiet? What is happening? And they are not ready to tell. There's another kind of patient who, is all trembling and crying when they reach our consultation. So that's not something to be done. The other set of people are who are just waiting, wishing it will go away, wishing it will go away, or they are too shy to talk about it. So they're too shy and they don't know whom to tell and how to tell. So I had a patient who was living in a very posh colony next to a hospital, and one IAS officer was like, and she was in her 40s. And when she came to me, she had a large breast lump. It was congregating and smelling. And her husband was on some tour, and when he came back, he was shocked, and he brought her immediately. She was an educated postgraduate woman, and with all facilities next door, but she was just shy, and she didn't know how to express it and to somebody, to her. She had only a son living with her. So that is the other end where you neglect. So either way it is neglecting. So remain calm and meet your doctor. Now what do you expect once you come to your doctor? So there will be examination of both your breasts and your armpits, maybe in the lying down and sitting posture. And you may be asked further tests like a sonomammogram, which is an ultrasound, or a mammogram, which is an X-ray film. Very rarely, MRI may be required to further your diagnosis. You may be asked for biopsies, the nipple discharge cytology. Don't get disturbed by these big terminologies. And you may be asked for certain blood tests. So now we are talking about these overt symptoms. Important is how the whole thing is, how do I detect these symptoms early, and especially the lump, and why so we will see shortly. So there are some simple steps to this. One is a breast self-examination. Second is regular checkup with your doctor, especially after the age of 50 years. And earlier, if there is a family history of breast, ovarian, and maybe colonic cancer in your family, you must start seeing your doctor maybe in your 30s. Regular mammograms as advised by doctors. Please do not do mammogram on your own. Don't go to a diagnostic center and get a mammogram done on your own without doctor's advice. It is meaningless unless it is interpreted. There are many interpretations to it, and there are many situations where you do nothing. There may be situations in the mammogram where you need to intervene, and don't do it on your own unless an expert has advised you, and you can go back to that expert and get that read and interpreted rightly for you. So now this breast self-examination, if you go on the net, you'll get a lot of them, and most of them are very accurate. Just a short way to describe is, one is you must look at your breast. Now this is breast awareness. It is not only self-examination, it is a way to become aware of your breasts and when they are normal, so that when some abnormality develops, you'll be able to easily detect it yourself. So you should stand in front of the mirror with your hands straight, with your hands on your waist and your hands raised. And you should look for any change in the contour, size, any retraction of your nipple or any puckering of your skin. The next is by actually touching your breast and feeling in the ways described. So you go once vertically, once in circular motions with the flat of your hand. And it will also be done in the lying down posture. Lying down posture is one of the best ways to detect where your breast falls flat, and anything deeply situated can be easily detected. Also, this examination, that is the second examination by touch, may be done during your bath with your hands and breast soaked. And with that slippery hand easily picks up a very small lump, if it is there, can be picked up more easily. So that's a good thing, that examination in the shower. How often? Now don't get panicky and do it every day. So when do you do? What is the frequency? So all young women should do it 1 to 2 days after the last day of their menstrual cycle. That is, we'll see, I told you that the breast gets congested premenstrually and it's heavy. And that time if you feel the breast will be very lumpy. So it has to be done immediately after 1 or 2 days after the menstrual cycle, so that the breast is less congested. The postmenopausal women and the lactating women can do it on a fixed day of the month, but the lactating woman must be sure that she has just breastfed the baby so that the breast is empty, and then examine. And women on oral contraceptives can examine them, do this examination on the first day of their menstrual cycle. Now, what is the advantage? See, the thing is, breast cancer is now increasing in India rapidly. It is said that 1 in 27 women in India is likely to develop breast cancer in her lifetime. And the older you are, this incidence will increase. Second thing is that younger and younger women are now developing breast cancer. The sad part is there is no way we can prevent. We know the risk factors. We know the factors that may increase the possibility of breast cancer, which is now, it's little outside of this talk today, Amit. That will be another long talk. And we can only decrease the risk factor. And the commonest would be your lifestyle, obesity, decrease your stress. It is very common in urban India. 1 in 30 women, that is not something to be taken very easily. And breast cancer is the highest cancer amongst women in India. That's the first, number 1 cancer in women in India. And the sad part is there is no way we can prevent. So the only thing we can do is we can detect it early. And the earlier it is detected, we can save the breast. You need not undergo removal of your breast. And we can save the life. And if it is really early, good outcomes, you may even get cured. This I would like to put a little in reserve, but yes, if it is really early, we have seen women living more than 10-15 years, that is equivalent to cure. So if you are getting screened, by breast self-examination once in a while, then that is the size of the lump, average size that you may feel. Whereas if you do regularly, you may get this size. And if you do your first mammogram, you may even pick up this small. And a regular mammogram picks up a lump so small, so small. Sometimes for us it's even difficult to take a biopsy of this, but it is there. And you can even imagine that is totally curable if you pick up in this stage. So this already I've talked to you that why are we worried about this? because of the rising numbers, because it's the younger women, more aggressive in younger women. And sadly, there's a lack of awareness and screening in India. And in fact, in the Western world, the screening has been the most important factor, which has resulted in early detection and saving of life, no loss of life, no loss of breast. And now, in all cancer fields, it is less and less surgery, more and more protection and preservation of the organ. So if you are early, then even you may not lose your breast. Okay? And the later you present, definitely your survival will decrease. But in all this, don't get again disheartened. The good news is that 80% of these breast lumps, 90% of these symptoms, what you saw, are non-cancerous. That is, they are not benign. So there lies my dictum, do not panic. 90% of early stage breast cancers are curable. And early breast cancer, 100% of them we can save the breast. You need not lose the breast, which is very, very psychologically, it affects the patients, spouses, especially the younger patients. Okay? But also, though it is occurring in younger women, less than 5% of the breast cancers occur in those less than 40, but it is not an impossibility. And of course, we have more than 2 million breast cancer survivors. So, moral of the story, if you have understood all the above points, they all point to one necessity, and that is breast awareness. That is, be aware how your breast feels by self-breast examination, get a regular test done a regular visit to your doctor. That if you are young, once a year should be enough. Screening by mammography once a year. Earlier, if your mother, sister, aunt, somebody in your family has had breast cancer, and since they are same thing to repeat, but reiterate that number of breast cancers are rising. It is a reality, and most present very late to us today, which is very sad. Be aware that a lot of places offer you mammograms and checkups and do a self-examination and see that we all work towards detecting breast cancer early, and breast awareness is the way to go. Thank you.
Thank you, Dr. Bharati. That was indeed very informative. I request all the audience to kindly type your questions, your queries in the chat box. Dr. Bharati will be answering them in the chat box. Next up, we have Dr. Kalaivani, Associate Professor of General Surgery. She'll be talking about hernia, stones, fissures, and hemorrhoids, myths busted.
Thank you, Dr. Navya, for that introduction for me. A very good afternoon, all the audience. I hope all of you are awake. And please type in your questions. This is an interactive session, so please type in your questions so that we will be able to answer your questions and doubts. This is a platform where you can interact with us. Please do so. So I'll be discussing, I will just tell what is important in these 4 topics, what we have. That is about the gallstones, the hernias, the fissures and fistulas and hemorrhoids. I will not go into the details of it. I will just tell you how they present and when they have to be treated. Next, please. Hernias. What are hernias? Hernias, everyone thinks that is something that has to be removed from the body. It's nothing but there is a defect in the body through which the contents inside your abdominal cavity, that is the intestine, you can see there, it's pointed. The intestine can protrude through that defect. Yeah, you can see there, it can protrude through the defect And this hernias actually need to be treated every time because it cannot be left untreated, because you can see the intestine coming out of that defect. So this can get stuck anytime in the future, resulting in what is called as obstruction. Means there will be a block in the movement of the intestine, and so that can produce a lot of other complications, which in turn can result in an emergency surgery. So you can see how the intestine comes out and what is the treatment is. There are no medicines for this and they have to be treated by operation only. And at this area, when the hernia occurs at this area at the umbilicus, it's called as umbilical or para-umbilical hernias. There could be hernias occurring anywhere in this region or below, or hernias could also occur after an operation. You can see here how this is a para-umbilical hernia, how it is left untreated and it's been there for quite some time and it has reached such huge sizes that has to be treated. And here, treatment for this, it could be a simple open operation wherein we cut open, we repair the defect, and then we place a mesh most of the time to see that the area becomes strengthened. This is strengthened. And this is a laparoscopic approach for repairing the hernia. That also could be done. So we can do a laparoscopic method or an open method. This will be decided by the surgeon after discussing with you. So this, if you have any symptoms like this, approach a surgeon, please. And if you have any doubts or questions, please put it on the chat box. I'll go to the next common problem, that is gallbladder stones. Before I go into the gallbladders, most of the time you come with some kind of pain in this area, or sometimes you'll have simply symptoms like gastritis. So you'll be thinking and postponing your treatment, thinking it's just gastritis and you'll be swallowing a tablet for that. So don't do that. Just find out why this problem is occurring. So this needs treatment from a surgeon again. So what exactly is gallbladder stones? You can see there is a small organ, this greenish organ, which is called as a gallbladder. You can see how it's related to your body. You can see these are the lungs, and below the lungs, below the diaphragm, you will see the liver. And just below the liver, you see this tiny organ, and this tiny organ can produce all these problems. I'll show you in my next slide. You see, it's again to understand the anatomy. This is the gallbladder, and this is the liver. Liver produces the bile juice, which drains through these ducts, and then they enter into the small intestine. After the stomach, the small intestine starts. So this communication, it goes down and drains into the duodenum, we call it, which is nothing but a small intestine. So what happens? Stones can get collected in this place. Do they need to be treated? And again, I say that these problems have to be treated by surgery only. There are no medicines as of now to treat gallbladder stones. Why should they be treated? One is you'll have gastritis symptoms, you'll be relieved of those symptoms. Second most important thing that we are worried about is the complications, these complications produced due to the presence of these gallstones. So what exactly happens? The stones can simply be here and they need not produce any symptoms at all. Sometimes the presence of the stones can produce something like gastritis symptoms, which I mentioned. Sometimes what happens, these stones can slip down into these bile duct and it will come to this place and it can get clogged over here. If it gets blocked over here, there are two organs that will be affected. The bile juice is not going down, one thing that can produce jaundice. Second thing is, if this gets blocked, this is a duct which connects to the pancreas, which is present behind the stomach. This also can get inflamed or infected because of this stone, because it is getting blocked here. So that can produce pancreatitis. And all these problems, what is called as the infection of the common bile duct, which is known as cholangitis, or an inflammation of the pancreas causing pancreatitis, all these are a kind of serious complications which we should avoid. And the other problem that can occur is if the stone gets collected over here, it can block at this point and pus can get collected in this gallbladder, which is of this size, can enlarge to a much bigger size, and that will require an emergency surgery. So all that we want to convey to you is, if you have any symptoms, get evaluated so that we rule out, not that all of you have gallstones, but if it is there, it has to be treated. And especially if they are diabetic, requires treatment definitely. You can just see how the gallbladder is removed, and you can see, so they can even have this many stones. These are all various type of stones that could be present. And the cause is mainly because of the kind of diet we are consuming. So what exactly we do, as I said, there are no medicines for this. We need to operate. And one is the laparoscopic approach, which is the gold standard now. We do it by 4 or 5 holes, keyhole surgery, wherein the gallbladder is removed and it is sent for a histopathology examination. So all this is done to prevent complications. Otherwise, once complications occur, then in that case, the stones, sometimes if it is present over here, it requires further treatment. And like, for example, if it gets clogged over here, sometimes we need to put a tube that is called as endoscope. It has to go through the stomach, and then we may have to remove the stone and then tackle the gallbladder later. So all these result in a lot of complications, and hence they have to be treated on time. Okay, this is another common problem. There are quite a few problems in the anus that many people come to us. So one such problem is, and for everyone, the one common term is piles. It's piles. When you say piles, there are many reasons for it. It is not just one reason for the pain or the bleeding that is present over there. So most commonly, people present with pain in the anal region, and what they say is, there is pain, severe pain after passing motion. Okay. Why does this occur? So the pain is because there is a cut here. Can you see that? This is the anal canal. This is the anus, and this is how it may look for you. There is a small cut there. What exactly has happened? You can see in this. This is a cross section of the anal canal. If you see, there is a cut in this region, and this is a highly sensitive area. So because of this, whenever the motion comes, it rubs on this, it causes severe pain. So you should understand what exactly has caused this pain. It is the hard motion that is passing through this. Okay, so what exactly is the treatment? The hard motion has to become soft. How does it become soft? First is with your diet. So eat such good food that is very rich in fiber, such that the motion is soft. That's first thing is the high fiber diet, means like cabbage, beans, and lady's finger, and greens, all kind of fiber. And it should be taken in such good quantities that they should be adequate enough. Okay, that could be your main course of your food. Along with it, good amount of water. So that will prevent and also will treat fissures. Okay, so important thing is the diet. And this also, if it is very bad, they need to be treated by surgery or by laser methods. We move on to one other simple problem which you all come across, hemorrhoids. Most of you say this is piles. So what exactly are hemorrhoids? Normally, if you see in the anal canal, so most of the time they present like this. There are small multiple bulges. They're not painful, but they may come with bleeding. The blood can be quite a good amount, like a splash in the pan, and it may be, you may be panicked by that. So again, you have to be the surgeon, so you'll understand what exactly is the problem. So what are these hemorrhoids? Hemorrhoids are nothing but, normally in this anal canal, there are small blood vessels here. Okay. Now, hemorrhoids means these blood vessels enlarge and they get pushed down. As and when the hard motion is rubbing on it, they keep pushing, and so they keep going out. There are various degrees of hemorrhoids. Depending on that, the treatment also will vary. So basically, it's a normal blood vessel. So when the hard motion again rubs on it, they can rupture and can cause severe bleeding. Okay. Very rarely, can you take out this? Very rarely, it can form a clot. You can see in this picture. I'm sorry about this. Yeah. Rarely it can cause a clot here, and that can be very painful. That has to be treated immediately, either by surgery or by medicines. Hemorrhoids again requires treatment. If they are bleeding severely, then it can be done by some injections, or it can be done by a stapler method or by a classical open operation. And here you can see how laser is being used for treatment. So there are various methods. Again, depending on the degree, the surgeon will decide. One final thing is fistula. Fistula initially starts as a pus collection somewhere in the anal region. They will usually come across with very severe pain in the anal region. That makes you so uncomfortable that we can see people walking in a very awkward position into the OPD. That's because somewhere some pus is collected and causes severe pain. And this has to be treated. And treatment is again by surgery only. So that has to be treated, and sometimes even after treatment, or if it is left neglected, they can result in what is called as fistulas. The fistula could be one opening here, or there could be multiple openings. Now, what exactly is this? You people will see these holes or openings in the anal region. What exactly has happened? You can see here. These are the holes which you see here. This is the anal canal. If you see, what you're seeing is only these two. They actually will be tracking back into your anal canal. And that has to be tackled. The treatment will be to remove this entire tract, or sometimes we have to give laser treatment to this entire tract so that this gets obliterated. Sometimes the fistulas can be complex, like they could be like, can you see this? There are multiple ones. And sometimes they could go so high that we may not be able to remove. So they have different methods of treating these things. But one thing you have to remember is, again, the treatment is surgery only. And better to meet the surgeon well in time, so that especially when the pain starts, meet the surgeon. And if the perianal abscess is tackled well on time, the fistulas could be avoided. I'm not going to talk anything more on these. I think I just mentioned important topics. If you have any questions, please put it on the chat box. I would be very glad to answer your questions. This is just showing how a fistulous tract can be removed. So we go to the entire tract from outside to inside and we remove it. Thank you. Thank you for your patient hearing.
Thank you, Dr. Kalaivani. I'm certain that this information has helped out many. Moving on, we have Dr. Pramila Kalra, Professor and HOD of Endocrinology, and Dr. Chitra, Associate Professor of Endocrinology. They will be speaking about diabetes and thyroid in women, what you must know.
Good morning, everyone. So we are going to talk about diabetes and thyroid in women. First, I'll be discussing a bit about thyroid, and Dr. Chitra will be taking us through diabetes. So we need to know a few things when we talk about thyroid in women. Now we know that thyroid is a gland which is situated in the neck. It is a butterfly-shaped gland, but this is very important for the normal functioning of the body. So whenever there is any problem with the functioning of the thyroid gland, whether the gland is secreting more hormone or the gland is secreting less hormone, it can cause problems. The more common scenario which is seen is hypothyroidism, where the gland starts secreting less hormone. And the other uncommon, less common scenario, I should say, is when the gland starts secreting more hormone. We know that women are more likely than men to have this thyroid disease. There are a lot of factors which are responsible, the X chromosome skewing and many other factors. And the autoimmunity especially increases after some situations like pregnancy, after menopause, and as the women grow older. And we know that women will develop thyroid problem more commonly during their lifetime. And these two are related also. When we are talking about hypothyroidism, we know that patients who have diabetes have a higher preponderance of hypothyroidism as well. Now, when we talk about hypothyroidism, now we know that it is diagnosed by doing a test which is called as a TSH and a T4 test, which is done in the blood. But we need to know, when do we need to do it? It's not that we always have to do it, but there are few situations, there are few symptoms where we should think about doing a thyroid test. Suppose somebody has like some dryness of skin, patient is feeling lethargic, there are some problems with the menstruation, patient's menses are irregular or they are not coming on time, or the patient's blood, the menstrual flow is heavy. And if the patient has some constipation, if the patient is gaining weight, that's not always the criteria to do thyroid test, because gain of weight can be because of many reasons. And the most common cause could be lack of lifestyle, lack of exercise, and lack of diet control. But in case we are doing a few set of tests to find out the cause, we sometimes do the thyroid test. But again, to add that that's not the cause of the weight gain alone. There are other factors which contribute to it. Also, there can be some psychological and psychiatric manifestations in untreated hypothyroidism. So if somebody has depression, lot of mood swings, somebody is feeling fatigued, is not able to focus properly, there is lack of concentration, even there is a sleep disturbance. These are all the situations where there could be a reason to do the thyroid test. Even if we have anemia, like if the blood hemoglobin is low, sometimes thyroid can contribute to it, so it might need to be done if the doctor thinks it to be necessary. Also, there can be sometimes other features of hypothyroidism if left untreated. Patient may have some amount of weakness, fatigue, muscle weakness. Even they can present with hoarseness of voice if left untreated for a long period. And again, in the same scenario, if the thyroid is not treated for a long period, there can be problems with the heartbeat. Patient can go to the cardiologist with a slow heartbeat, and they may also have problems with their cholesterol, which we call as lipids. So patient may get high cholesterol value, and sometimes thyroid can be the cause of it. So these are all the features where we need to check, or we might need to check thyroid, and we need to see if the patient has any evidence of thyroid disease. Also, it is very important that when a woman is planning for a child, the thyroid should be normal. Again, I would like to stress on one thing here, that it's not that if a woman has hypothyroidism, then she'll have problems with conception. But if she is not treated properly with the hypothyroidism, then she may have problems with conception. So if a woman has developed hypothyroidism, or if a girl has developed hypothyroidism, and she is treated properly, and her TSH is kept to the normal target range required for a woman to conceive, then there won't be any problems because of the thyroid per se for her conception. In case a woman is not treated with the medications for hypothyroidism, then she can develop some problems during her pregnancy, which can range from a miscarriage, which can happen in the few initial weeks of pregnancy as well. She can again have anemia during pregnancy. Even it can lead to IUD and stillbirths if the thyroid is not treated and the thyroid levels are high, TSH is high during pregnancy. She can land up with a preterm delivery or a low birth weight baby. There can be some problems with the brain development of the child. But if a woman has hypothyroidism, her TSH is kept to the target as decided by the doctor for her pregnancy range, then there won't be any such problems because of the hypothyroidism. Also, it is very important to understand that if a woman who is pregnant and she is already on thyroid medications and she conceives, she has to probably increase the dose of the thyroid medication, which again has to be decided by the doctor. But by no chance the woman should stop her thyroid medication. She should continue, and she should meet her endocrinologist or her treating doctor at the earliest, so that the thyroid dose is adjusted as per her pregnancy range, which is required. And in pregnancy, we need to have a more regular follow-up for the thyroid levels. 4 to 6 weeks to 8 weeks follow-up is required to titrate the medication during the pregnancy. And it is very important that after the woman delivers, the thyroid dose is again adjusted as per her TSH value, because then after delivery, the requirement of thyroid medications may come down. Also, it is important that all the babies who are born, their thyroid levels should be checked after 72 hours of birth, irrespective of whether their mother had hypothyroidism in pregnancy or she didn't have. The treatment of hypothyroidism is very simple. It is just a tablet which a woman has to take in the morning and just have to check her TSH levels 3 to 6 monthly once. There is a specific diet about thyroid, because a lot of times we are asked the question that is there any specific diet for thyroid? No. The answer is no. Government has iodized the salt, so we should all use the packet iodized salt. We don't need to restrict vegetables like cabbage or cauliflower or broccoli. If anybody has hypothyroidism, they can take the normal healthy diet. But everybody has to follow a healthy diet. It doesn't mean that if they have hypothyroidism only, they have to follow a healthy diet. It's overall, we tell everyone to follow a healthy diet with a good balance of carbs, which are low in glycemic index, with predominant fiber, with good amount of protein and some amount of fat, which is required. So that's the healthy diet they have to follow, but there is no specific diet which needs to be followed for a patient who has developed hypothyroidism in the form of restriction of any of the vegetables or any of the products or the cold items or curd or milk. They can take everything in their diet as per the recommendations for a normal healthy diet. Now coming to the other entity of it, which is hyperthyroidism. Now we talked about hypo, where we said that they may have cold intolerance, they may come with lethargy, they may come with depression, mood swings, they may have heavy periods, they may have pulse rate which is slow, they may have some brittle hairs, they may have a wall of hair. All these things can happen. But few are the things which can happen in hyper. Now, what is hyperthyroidism? Hyperthyroidism means when the thyroid is functioning more and the thyroid gland is secreting more hormone. So in such scenario, mostly the opposite of what happens in hypo may happen in hyper. So the patient may come with weight loss. So if a patient is losing weight all of a sudden, has fast heartbeat, palpitations, she has more sweating, anxious, sleep is not proper, she has lot of weight pains, she may even come with bone ache, bone pains and all. There may be a lot of symptoms. But again, to add that these symptoms may not be only because of hyperthyroidism. There may be so many causes of these symptoms. But if a woman has any such symptoms, it is justified to screen her for thyroid in case the doctor thinks so. They may also present with loose motions. All these can be symptoms which can manifest. So predominantly, if there is a sudden weight loss which is happening, there can be many other reasons, including diabetes, which can be one of the factors for the sudden weight loss. There can be some cancers which can cause. It's not that only hyperthyroidism will cause weight loss, but that is one of the reasons where we need to screen for the thyroid to see if there is any problem with the thyroid gland secretion of the hormone. Again, this is also a disease which can be treated mostly with medications. Yes, there are few other therapies like surgical options available in case it is needed for few patients, but most of the patients can be managed with medications, and the medications have to be continued as per the doctor's advice. Again, a woman who has hyperthyroidism should get her thyroid levels controlled before she plans for a child. There are definitive treatment options available in the form of radioiodine, which can be done if a woman is planning for a child before she tries to conceive, so that by the time she's planning for conception, her thyroid levels are in the normal range and there is no roller coaster for the thyroid hormone levels. So that is also a disease which can be easily treated if the patient goes to the doctor on time and follows the instructions and the medications as advised. The treatment, as I said, is with tablets. Radioiodine and surgery may be needed for very few cases, surgery. Some cases may require radioiodine, but that's a very safe treatment. And after taking radioiodine, women can plan for a child after 6 months of taking the radioiodine. So that's also a safe treatment. If the doctor thinks that it is necessary for the woman, then she can take it and she can have a normal pregnancy after taking radioiodine. There is no problem with that. Even if the surgery is done, then also the woman can have a normal conception with the medication support with the hypothyroid drugs which will be required, because once the thyroid gland is removed, she may become hypothyroid and she will require levothyroxine supplementation. But again, there won't be any problems for the woman. So I think this is where I end, and I hand it over to Dr. Chitra to talk about diabetes in women.
Thank you so much, Dr. Pramila, and a warm welcome to everybody in the audience, and congratulations on taking the first step to improving your own health. The women doctors of Ramaya Medical College take pleasure in congratulating you. So we do know that diabetes is becoming very, very common, but specifically for women with diabetes, what is it that we must all know? So we all know that if we have one family member with diabetes, we are at risk for diabetes. We know that if we're leading a sedentary lifestyle, which is where we're sitting down quietly in a place for most of the day, that is a risk factor for diabetes. We do know that if our weight is greater than a BMI of 23, and you have many online calculators where you can check your BMI. If your BMI is greater than 23, you are at risk for diabetes. But one risk factor, which is specific for women, and I want all the women in the audience to pay attention to, is that if you've been told during your pregnancy that your blood sugar levels are high, that means you're at increased risk for type 2 diabetes in the future. Very often we see women walk in their 40s and early 50s with the first diagnosis of type 2 diabetes, only to tell us that their blood sugars were discovered to be abnormal during pregnancy, but after that, they were sensitized to keep checking their blood sugar levels annually. So if your blood sugar levels during pregnancy were high, it's very likely to become normal right after delivery. But it requires that we keep checking our sugars every year around your birthday or your child's birthday to make sure your sugars are continuously normal throughout. And the second important aspect of risk factor for diabetes, which might play a major role in women than men, is the role of stress as a risk factor for type 2 diabetes. We tend to take on the entire family's burden on our minds, not aware of the fact that maybe we cannot change too many things about people's behavior, and the continuous stress could potentially worsen our risk for type 2 diabetes. So take a look at this graph, mark your own risk factors, identify your own family members' diabetes history, and find out your risk factor for diabetes. Moving forward, the complications related to diabetes remain pretty much the same between men and women, but there are some key differences that I want you to understand. Although the prevalence of diabetes is almost equal between men and women, here you see that the number of women with diabetes who lose their lives is much higher in women than compared to men, especially after they cross the age of 60 years. This is a very, very important point. Although we are treating diabetes, maybe we are not effectively managing it throughout due to so numerous socio-cultural economic factors. The other point that I want the audience to pay attention to is the fact that diabetes as an important contributor to death begins even as early as 30 years of age. So there is no age below which you are protected from type 2 diabetes. Type 2 diabetes is the diabetes which happens primarily due to lifestyle. It was usually a disease which occurred in the 50s, and then it became common to have it in our 40s, and now recently, we are not at all surprised when we have 10-year-old and 12-year-old children being diagnosed with type 2 diabetes. So, who should test themselves for diabetes? Everybody. No age group is protecting you. So, take a look at the risk factors and assess your own risk. The third important point, why are we losing so many women with diabetes, although the prevalence of diabetes is equal between men and women? We all do know that men are at greater risk for heart disease. But if you take men and women who both have diabetes, you see that having diabetes increases the risk of heart disease in women by 4 to 5 times. What this means is, if you have a family member who's a woman who has diabetes, go through the list of medications that she's on and make sure that she's on medications which prevent the risk of heart disease. The most commonly used medication to reduce the risk is statin. So the entire class of medications which end with statin is a medication which reduces your risk of heart disease. In some situations, they might also be on antiplatelet drugs or blood thinners like aspirin and clopidogrel. So do this for all the women with diabetes in your family. One quick question, give me a number which pops in your head. What percentage of pregnant women do you think have high blood glucose levels during their pregnancy? 10%, 20%, 50%. And this is data from Southeast Asia, which is the area that we come from. Roughly 24% of women in pregnancy have hyperglycemia, which means if you have 4 pregnant women, 1 out of the 4 is likely to have sugars which are high. Why should we worry about mother's blood glucose levels during pregnancy? Isn't it okay for the mother to have high blood glucose, then the baby will be fine, right? No, that is not the truth. Mothers whose blood sugar levels are high during pregnancy are likely to give birth to children who are at increased risk for diabetes. I will say that again. Treating mothers' blood glucose levels during pregnancy reduces the risk of obesity and type 2 diabetes in the child. So that's exactly why all pregnant mothers or even mothers who are even planning pregnancy should get their blood glucose levels checked and make sure it is normal even before you get pregnant. You must be listening about women who have after pregnancy discovering that their sugars are more than 200, more than 250. High blood sugar levels during pregnancy can be detrimental to both the pregnancy and the fetus. Dr. Nandini is going to talk to us about PCOS, but is there a connection between PCOS and diabetes? Is PCOS just irregular cycles? And now PCOS has become so common. If you take all the adolescent and young women population, up to 10 to 25% of women have PCOS in some form of the other. But the only point that I want you to carry from here is that PCOS is not just a reproductive disorder. It is a metabolic condition with reproductive manifestations, which means the same girls who have irregular periods or acne or increased hair growth are also at increased risk for type 2 diabetes, also diabetes during pregnancy. So while you're getting all your hormones levels tested, before you get your laser done, before you get your acne treated, your endocrinologist is asking for blood sugar levels and cholesterol to identify these risk factors as well. So I've scared you so much about diabetes. Does that mean we are all going to get diabetes? No, not really. Diabetes is an extremely preventable condition. Over 50% of type 2 diabetes can be prevented by simple actions that we take as a family. We decide how our family spends recreational time. We decide the food that goes on our family's plate. Unfortunately, it should be equally divided, but that's the way it is now. We decide what goes on the grocery list so we can control many of the risk factors which can change our family's risk of getting type 2 diabetes. So choose healthy, choose fresh produce, more vegetables, more protein. We are all eating less protein vegetables as told by Dr. Pramila. It's the same healthy diet for thyroid and diabetes and overall well-being as well. This is what a healthy plate looks like. 50% of your plate with vegetables, 25% of your plate with protein, and another 25% of your plate with vegetables. So today when you're eating lunch, take a look at your plate and see if your plate has this many vegetables and this much of protein in it. So when we say grains, we mean rice, ragi, chapati, idli, dosa, all of that. When we say protein, we mean dal, curd, egg, fish, chicken. And when we say non-starchy vegetables, they are vegetables which grow above the ground level. And reduce the intake. All of the junk which is here is very, very tasty. It is tasty for a reason. The companies which are making them are investing heavily in research done to get us all hooked to this food. And it is very difficult to resist, but it's important that we moderate and gate the amount of this food which comes into our life. And stress is an important risk factor for diabetes. Night shift workers and staying up through the night and not prioritizing sleep is an increasing risk factor for diabetes as well. So take time to unwind and relax, find your support group, get active more often. Healthy comes in all shapes and sizes. It looks different on everybody. So work towards improving your health on a daily basis and break the bias. Women are taught that caring for your entire family is the way for all women to be, and that bias needs to be broken. Taking care of yourself is not selfish. Taking care of yourself is the need of the hour. Prioritize your care, screen yourself for diabetes, and take steps to prevent and manage diabetes. Thank you.
Thank you, Dr. Pramila and Dr. Chitra, for such extensive information. I now request Dr. Nandini, the Department of Obstetrics and Gynecology, to deliver her talk about PCOS, health implications and challenges in management. The audience are requested to type in their messages in the chat box.
Cheers.
Good afternoon to all of you. Maybe some 30, 40 years back, we had not heard about polycystic ovarian syndrome. Now, any girl around the age of 16 years, 18 years, goes with any pain abdomen, it is the person who is just taking care will just ask for an ultrasound. Once the ultrasound report comes, it is come as polycystic ovarian syndrome. So either the girl is worried, and naturally the parents, especially the mother, is worried. And once the scan report shows polycystic ovarian syndrome, the girl usually, and all of you know that they are internet savvy, Google savvy, they open Google, and once they find out, they are very much scared. At the same time, they want to know more about the disease.
So once you open Google, there is a lot of confusion. What is the reason who is having polycystic ovarian disease? And many times it is, most of the time, who will tell a review that I had, but I'm healthy, nothing has happened to me. So better is they consult a gynecologist. So the reason is, though exact incidence is not known in India, in Western countries it is very clear. In India, we have seen that it affects around 4 to 6% of the women. The incidence is increasing mainly due to the change in the lifestyle and especially the stress. Stress in young girls to do very well in life, to take most of them are stressed due to the NEET exam, at the same time stressed due to various other factors. And we have noticed that it is one of the most common cause of anovulation. 20 to 25% of the women with normal ovulation also will demonstrate the ultrasound findings of polycystic ovaries. So what does it mean? We have seen that PCOS prevalence is, though there is limited data in India, we have seen that it is around 3.7 to 22.5%. In different regions, the incidences varies because exact record we don't have. So now, what is the pathophysiology? Pathophysiology, you know very, very clearly, the girl will have irregular cycles. Irregular cycles, and it is due to oligo-ovulation or anovulation. So this is mainly due to the difference in the hormone level. So to tell, basically there is a hormone imbalance, and usually the girl will have irregular bleeding. And usually it is associated with increased androgens. So what does androgens mean? That is, there is increase in the free testosterone level, so there is associated hirsutism. So what do you mean by hirsutism? There is excess hair growth, especially on the chin, upper lip, at the same time around the breast, periareolar region, and also on the abdomen. And on ultrasound, you find that the ovaries are enlarged. There are multiple peripheral cystic follicles which fail to mature due to the increase in the androgen levels. So, what are the common symptoms? Common symptoms, most of the time, it is irregular periods. Whenever there is irregular periods, and due to hyperandrogenism, there is acne, there is excess body hair growth. And if the obesity is there, there is associated acanthosis nigricans, that is nothing but darkening of the skin, especially on the neck as well as on the axilla. And there is increased weight gain, especially around the abdomen. And there is baldness, and associated other factors, there is headache. So now coming to the symptoms, there may be hair loss, and there is hirsutism, and there may be pelvic pain, and if the girl is married, there is chance of infertility, and there is obesity and irregular periods, and there is associated fatigue and high testosterone levels and acne. So now how to diagnose? There are various ways to diagnose. One important is Rotterdam criteria, where if you do an ultrasound, you see the follicles, which is more than 12, measuring 2 to 9 millimeters in diameter, and more than 12 follicles on ultrasound. And if at all you see, it looks like a necklace. We tell it as the necklace pattern. So it was Rotterdam who decided to find out the criteria. So the criteria is irregular periods, there is high androgens, and there is multiple cysts in the ovary. In other ways, it is polycystic ovaries. So now, what is the goal of management? One is, you should know very well that a woman who has menstrual disorder, especially young girls, aim is to regularize the menstrual cycle. And if there is hirsutism, it is so much disheartening for the girl, especially going to the school, going to college. We have to treat hirsutism. And married, ideal would be to treat infertility. And it is not just in the young girls, it is having long-term implications, so long-term effect of X syndrome, that is in later life. So it should be a whole lot we have to treat starting from puberty. The main idea of telling is you should not neglect polycystic ovarian syndrome. So management, non-pharmacological, pharmacological and surgical. Non-pharmacological, nowadays they have seen a lot of research is going on. If at all you open an internet, you may even get 1 lakh papers about polycystic ovarian syndrome. There is a lot of research going on to find out the etiology.
though there is some genetic material, genetic involvement, but nowadays they are saying it may be an inflammatory process also. And they have related it to though lifestyle changes, they have also related it to diet. Diet, they have seen that it is most of the time the junk food. So especially when young girls are brought to us with obesity, important is to find out the diet. Most of the time, they are very fond of eating pizza, they are fond of eating burger, they are fond of eating chips, and hardly taking any vegetables. So, non-pharmacological ideal would be to tell them about lifestyle changes, especially to reduce weight. Once they reduce the weight, automatically the cycles become regular. And once you reduce, usually it is going to help in regularizing the cycle. At the same time, hirsutism also is going to come down. Coming to the pharmacological as well as the surgical treatment. Surgical treatment, especially for a lady who is married and who is having infertility. Pharmacological, various drugs are available, which I'll be telling. So now, PCOS treatment, important is, first line of treatment is to reduce the weight. 5 to 10% loss of weight also is helpful to regularize the cycle. At the same time, it is going to improve the risk factors. And if a lady is married, especially due to anovulation, that is, there is an imbalance between estrogens and progestogens. The progesterone is less due to the decrease in the LH factor. So, LH factor is increased, follicle stimulating hormone is more. So, important is as there is decrease in progesterones, especially the effect of estrogen, there is endometrial hyperplasia due to chronic anovulation. Whenever there is endometrial hyperplasia, there is chance of the person having menorrhagia, and later the patient may develop endometrial cancer. So important is to see that there is unopposed estrogen is decreased. So you can treat with combined oral contraceptive pills. So whenever you are planning the treatment, depending on the age, depending on the whatever is the main complaint. For example, if the girl comes at the age of 18 years, 20 years, important is to advise about lifestyle changes, at the same time advise about weight loss, which is going to help. And the lady who is married, has infertility, then we can try ovulation induction, at the same time reduce the weight. And lady who has married and has children, again possibility of endometrial hyperplasia. That time you are going to treat with oral contraceptive pills. And especially we have seen that there is associated insulin resistance, so you can use metformin also. So to decrease hyperandrogenic features, you can do combined oral contraceptive pills, you can use spironolactone, you can do finasteride, and especially if hirsutism is so much bothering, they can use electrolysis as well as vaccine. But important is all this should be under the guidance of the doctor. So now it is not just, there is a lot of controversy regarding the name also, whether it should be named as PCOS. Now a lot of people are telling it should be named as a metabolic syndrome because there are long-term implications. So short-term implications, there is obesity, there is infertility, irregular menstruation, and all of us should know that it will lead to obesity associated with abnormal lipid levels. There is hirsutism, acne, and alopecia. And associated there is glucose intolerance and acanthosis nigricans, which may be very distressing for the girl going to college. All these should be kept in mind. Long-term implications, diabetes mellitus, endometrial cancer, cardiovascular disease, hyperlipidemia. Thank you.
Thank you, Dr. Nandini, for enlightening the audience regarding this highly prevalent disorder. The audience can kindly type the questions in the chat box. Next up, Dr. Vijayashree, Professor of Department of General Medicine, who will be talking about health screening for women.
How many have logged?
42.
Good afternoon to the audience. So you have heard so far about all the various problems which plague women, and I'm here to talk about what we could do to prevent some of them. So The lifestyle definitely goes a long way in preventing a lot of diseases, and you have heard about that from all the specialists who have spoken until now. So there are also certain things that you could do, which you could, by which you could actually detect the problems much early in the course of the illness, and hence you could also prevent the complications that can occur as a result of these diseases. So why screening tests are important? An old saying, an ounce of prevention is worth a pound of cure. So getting checked early can prevent certain diseases in the very beginning when they are easier to treat. Screening tests can spot illnesses even before you have any kind of symptoms. So one thing which has not been touched upon until now is high blood pressure. So is it necessary to check your blood pressure frequently? Definitely it is, because as you grow older, your risk of blood pressure increases, especially if you are overweight or you have certain risk factors. So what are the certain risk factors? Like I said, age itself, postmenopausal state, that is a lady who has already achieved menopause. Then stress also plays a role. Weight, if a person has an increased body weight, that can be a risk factor. Having diabetes also is a risk factor. Having certain thyroid disorders can be a risk factor. Certain medications could lead to you having a risk for high blood pressure. So these risk factors can be evaluated by your doctor. Now, why high blood pressure needs to be detected early is that it can cause life-threatening heart attacks or strokes without any kind of warning. You may not even be aware that you have a high blood pressure unless and until you check for it frequently. So the American Heart Association says that if your blood pressure is below 120 by 80 millimeters of mercury, which is the ideal reading, you should have it checked at least once every 2 years, even if the person is above the age of 20. So you think why a young person has to check for their BP? It is necessary. And the earlier you pick up, and we do see people who are very young, who are below the age of 30 coming often with a high blood pressure. We see medical students in our own hospital coming sometimes with high blood pressure. So it is necessary to check it for it every 2 years, even if you feel there is nothing wrong. At the age of 40 or more, or with other risk factors, an annual screening is required. The other thing that we all hear about in the media all the time is about cholesterol. Now, cholesterol is nothing but it is a substance that is found in your blood, and it can have various levels. There are certain normal levels which are required to be in good health, and it is also a substance which is required for normal functioning of many of our bodily functions. However, a high blood cholesterol can cause plaque, or it can actually clog your arteries. So it is a buildup, basically a lipid buildup in your arteries, which can cause narrowing of the arteries and lead to reduced blood circulation in that given area. Now, plaque can build up for many years without any kind of symptoms and eventually cause a heart attack or stroke. So both a heart attack or a stroke result because there is a narrowing of the blood vessels, leading to a decreased blood circulation into that part, whether it is to the brain or heart or sometimes even to other organs as well. Now, you can do a cholesterol check. If your age is 20 or older, you should have it done every 5 years. If you have a total cholesterol of less than 200, it is an ideal thing to have. If you have a cholesterol between 200 to 239, then it is a borderline high reading. What could we do to prevent cholesterol from going up? One is definitely a diet, a lifestyle which has been stressed upon until now about regular physical activity. And what is regular physical activity? Since no one has talked about it until now, I would say about 30 minutes to 40 minutes of a brisk exercise like walking or jogging would be enough if you do it for 5 days out of 7 days. So that is enough to keep a lot of diseases at bay. Now, cholesterol could also be a result of your genetic influences. So it's not always that someone who is lean, who's regularly working out, would always should have a normal cholesterol. It is possible that a person who is in good health might also have a high cholesterol. So checking for it periodically and also getting it treated likewise is very important. Now, the other thing which is very unique for women is this problem of cervical cancer. I'm sure all of you would have heard about it from media. Now, cervical cancer, this is also called, cervix is also called as the mouth of the womb in common layman terms. And what you could do for making sure that your gynecological health is quite okay is with regular pap smears. Now, a pap smear is nothing but a scraping of the mouth of the womb, that is from the cervix. You take in a scraping from the cervix, and that is checked to look for any cancer-like cells. Now, with regular pap smears, cervical cancer is easy to be picked up early, and they may find abnormal cells in the cervix which can be removed before they even turn into cancer. So, early cancer can be treated quite well. The main cause of this cervical cancer is a virus, actually, which is a human papilloma virus, and it is a kind of a sexually transmitted disease.
Industry, the questions.
There are ways actually to prevent cervical cancer. One of the most important thing is a vaccination. You could give a HPV vaccination to girls who are not yet sexually active, and it should be promoted in a big way, actually, which is not caught up very much in India, but we should promote it and advocate vaccination for women before they become sexually active. So beginning at the age of 21 and until the age of 65, you could have a pap smear every 3 years, according to the US Preventive Task Force. And if you're 30 years or older, you can have the test every 5 years if you combine it with a screening test for this human papilloma virus. Breast cancer, Dr. Bharti already covered about this in detail. If you're in your 20s or 30s, your healthcare worker should perform a breast examination as part of your regular checkup if you are going for a medical exam at any point of time. Now, another way in which you could pick up breast cancer would be through a mammogram. Now, a mammogram is a test which screens for breast cancer. It is a radiological diagnosis. The American Cancer Society recommends annual screening beginning at the age of 45 and then switching to once in every 2 years at the age of 55. Now, women with a higher risk of breast cancer, that is, if there is a female relative, a mother, an aunt, or a sister who has had breast cancer, then the frequency of this mammogram may be much more, and they need to be followed up very, very closely because there's high risk of it occurring in them. Now, the next problem is osteoporosis. Now, what is osteoporosis? Osteoporosis is nothing but a weakening of the bones. Now, this is a process which starts quite early, actually. It starts somewhere in your 30s and it can be progressive. Now, there are certain things that we can do to prevent a fast progression of osteoporosis. One is, again, physical activity. Now, regular physical activity, it reduces the rate at which osteoporosis occurs. It will invariably occur with age. There's nothing that we can do to totally prevent it. However, we can slow the rate of this occurring. Now, why should we be worried about osteoporosis is that it can lead to fracture. So fracture need not be with any great kind of trauma. Even a small fall, even just slipping from the chair or from the bed can cause serious fractures, and they will lead to a lot of morbidity in the person. It can cause a reduction in the height of the person, difficulty in walking, in movement. In many aspects of life, osteoporosis actually worsens our quality of life. So it's important to take care of this. Adequate calcium intake, adequate sunlight exposure, being careful about medications that you take which could promote osteoporosis, all these need to be looked into. And if you are a candidate for osteoporosis, if there has been a history of fractures in the past, it is quite likely that you have osteoporosis, and you need to talk to your doctor regarding how to go about treating this. In terms of screening, we can do what is called as a bone density screening. Women should start getting screened for osteoporosis with a bone density test at the age of 65. For this, a test called DEXA scan is used. The frequency of the screening varies depending on bone density and other risk factors that a person has. Again, diabetes has been spoken about in length. The recommendation is starting at around the age of 40. Women should get a blood glucose test every 3 years to check for diabetes or pre-diabetes. And if you have gestational diabetes, like she mentioned, it might be much more frequent. Maybe annually you could look for your blood sugar levels. Now, fasting blood sugar of more than 100 and lesser than 126 is called as being a pre-diabetic. That means the person has still not gone on to develop frank diabetes, but is at a great risk of developing diabetes in the future. If a person's fasting blood sugar is more than 126, it indicates over diabetes. Also, a random blood sugar taken at any point of time, more than 200 also indicates that the person has diabetes. If one is obese or has a family history of diabetes, screening has to start earlier and should be tested much more frequently. Screening for diabetes for all adults should be done between 40 to 70 years, irrespective of whether they have any risk factors or not. Coming to another condition called as colorectal cancer, this is nothing but a cancer of the large intestine. Now, why do we have to worry about this? Is that it is the third most cause of cancer death in the US, and in India it ranks 6th or 7th among all the cancers. So, symptoms can be quite occult in the sense they don't come into light for a very long time. Some people may have symptoms like bleeding in the stools, or they might have constipation, or sometimes they may have irregular bowel habits wherein they have diarrhea for some time interspaced with constipation. There may be multiple ways in which colon cancer may present. Sometimes there might be even be a family history of colon cancer in a parent or a sibling. Now, how do we screen for colorectal cancer? Now, a colonoscopy is a common screening test for colorectal cancer. While the patient is mildly sedated, a doctor inserts a small flexible tube equipped with a camera into the colon. Another type of test is a flexible sphygmodoscope, which looks at a smaller portion of the large intestine, particularly the lower part of the colon. You could also do what is called as a stool fecal blood test, or FBT. Now, stool local blood could be done almost every year, and you can look at whether it is positive. Stool local blood, or there are traces of blood in the stool, indicates that there might be need for further investigation like a scopy. Now, unless a problem is found or there is a greater risk of colon cancer, a sphygmodoscopy is repeated every 5 years and a colonoscopy is recommended every 10 years. Screening for this should start at the age of 50 and continue until the age of 75 years. The body mass index was mentioned in the diabetes talk. So it is a simple calculation which takes into account your weight and your height, and you get the number. And normal body mass index is between 18 to 23 for in the Indian population. Now, starting at the age of 18, adults should be screened for obesity, which requires having a body mass index calculated. Your BMI indicates whether or not you're obese, and which raises the risk of problems which we have already mentioned at length. Another thing all women do forget is to do a skin examination. And by skin, I do not mean only the facial skin on which we concentrate. But skin examination of all parts of your body should be done regularly. You look for any new moles or changes in existing moles, which can be an early sign of skin cancer. Though this is not a very common occurrence in the Indian population and is more commonly found in the West, but we too need to be aware of this because there are instances where we do see skin cancer as well. And what we forget is also a dental checkup. All adult women need a biannual dental checkup to look for any kind of problems. It could be gum-related problems or it could be tooth-related problems. And sometimes they could be the most painful kind of problems that we can have. And they can escalate into certain serious problems as well if they go into the soft tissue. So even if your teeth are healthy, please remember to have a biannual dental checkup. Now, screening for STDs or certain sexually transmitted diseases. Now, this is for those group of people who are at high risk generally. Now, what do we mean by high risk? People who have more than one sexual partner, they need to be screened for STDs regularly. Now, the conditions that we look for are chlamydia, gonorrhea, more than at 24 years, or those who are at risk, hepatitis B, HIV, syphilis screening. And this is also done prenatally, that is when a woman is pregnant, it is usually carried out these tests. And HIV is done in all individuals aged between 15 to 65 years whenever they come for any kind of medical checkup. It might be a regular surgery or it might be some other illness wherein the doctor feels that it needs to be screened. Hepatitis C is a one-time screening for adults born between 1945 to 1965. This was a time when this was not actually being screened at all, and many transfusion-related transmission of this virus happened at this point of time when it was not a regular or a routine process to check hepatitis C in the blood of donors. In people with increased risk, hepatitis B, C, and HIV testing may need to be done much more frequently. So in summaries, I put up a table for you. So whichever age group that you do belong to, these are the tests that you should do regularly.
You can't.
You could take a screenshot of this, whatever you're having, whatever device you're using. So this is a simple tool for you to know what are the things that you have to look at depending on your age group. So proper screening won't always prevent a disease, but it can often find a disease early enough to give you the best chance of overcoming it. Thank you.
Thank you, Dr. Vijayashree. The session is now open for questions for all the panelists. I request all of you to kindly wait because our principal and dean, Dr. Medha, will be giving the final comments.
We wait for
Questions?
yeah,
Okay.
just say anything.
There is a question. Does washing your hair every day increase the risk of hair loss? I request Dr. Sumati to.
You can speak from there only, I think.
Washing of the hair daily does not result in increased hair loss. And the, should I say, and the sample, I wash my hair practically every day.
Thank you, ma'am.
Thank you, ma'am.
Next question.
Next question. I am 67, had my hysterectomy at the age of 36, developed seronegative rheumatoid arthritis at the age of 50, which aggravates once in 3 to 4 years. Latest was in 2018. Since then, on hydroxychloroquines, Folitrex, Folvite, since then, along with hereditary factor losing hair, now it's very scanty, going bald at the backside. The quantity of hair is almost invisible. Any hope?
Okay, looking at the factors that you have mentioned, you have many factors which could have caused your hair loss. Like medications like hydroxychloroquine, Folitrex are well known to cause hair loss. However, they usually do not cause the hair loss that you have mentioned. There is going bald at the back side, which is the type of hair loss that you see in male pattern, which is genetic. And so you have to look into that more than the drugs themselves. However, the drugs could contribute to your hair loss. And if it is caused by Folitrex or hydroxychloroquine, they are usually reversible. There is no issue with that. There are many other things, diet, besides all this. The diet has a toll on the hair fall, and if there's anemia, which usually occurs in people who have rheumatic disorders, rheumatoid arthritis and diseases like that, they're likely to have chronic anemia, which by itself, that can cause hair loss. So probably we'll have to study the kind of reasons behind the hair loss, but genetic male pattern baldness appears to be some important thing in the case. I hope that will answer your question.
Thank you, Dr. Sumati. There's a comment in the chat box that was such an enlightening talk on breast awareness, Dr. Bharti. We were able to understand everything you spoke of. Thank you so much and looking forward to more talks from you. If there are any other questions, kindly please feel free to type them in the chat box. It will be answered by all the panelists. In the meanwhile, I request Dr. Medha Rao, Principal and Dean, to provide her valuable opinion and insights about the Women's Health Awareness Program, which was her brainchild.
At the outset, hello to everyone who have logged in. Let me express a combined gratitude to all of you. This is an initiative which was taken by the women doctors of Ramaya Medical College way back, and they have done a sustained effort and continued this session for the last few years. Let me just share what was our objective. We women, the group of women doctors in Ramaya Medical College, started this initiative with a primary objective of helping our women friends. We had the objective of having a strong womanhood as well. And why did we choose on health? Because health is wealth. A healthy woman will create a healthy family. With that in mind, in spite of their busy schedule, all the women doctors in Ramaya, a lot of them have put in this effort to give a comprehensive overview of certain disorders. I'm pretty aware that we may not have covered all the diseases. Nevertheless, the most common disorders have been covered, and the preventive strategies, which are going to go a long way, have also been detailed. We appeal to all the women folk to log in every year whenever this announcement is made, purely for the benefit of everyone who logs. I cannot help but appreciate and congratulate all my women friends in this institution who take this effort and the pain of talking to you and giving you all the overviews. They're also willing to answer all your questions. Not just this single day ka CME. I am also going to tell all of you that please feel free to contact them and meet them in person whenever you have any health issues, and they're always going to be there to help you out. That said, let me again remind all of you, not just log in for your own benefit. Would you please spread this message among your women friends, women colleagues, women neighborhood, to please log in every year, because this is an initiative which is going to be a sustained effort. On behalf of all the women friends who have logged in, let me congratulate my colleagues and friends in Ramaya for doing this job for all of you. Thanks to everyone. Have a nice weekend.
Thank you, Dr. Sheras. I thank all our faculty members for taking out time and providing us information about these important and highly prevalent disorders. In the end, we again emphasize about the theme, gender equality today for a sustainable, gender equality today for a sustainable tomorrow. The link for this entire event will be available on YouTube. Kindly spread the information among others. Thank you.
Thank you, ma'am. Thank you so much. Thanks to all the speakers for, in a very short notice, it has been prepared. Thank you for your kind cooperation.
We enjoyed it. Yes.
Thank you,
Yeah, really a special thank you and congrats to Dr. Kalaivani.
Thank you, ma'am.
for doing this. So I noticed all of you almost spoke as if it was learned by heart and very well rehearsed. And I feel so good about the eloquence. The eloquence was so good.